All right, so inflammatory disorders, you're going to separate into three sections of the heart. There's the pericardium, the myocardium, and the endocardium. All right, so I think the next slide will split up more, but the pericardium is peri, or being around. That's what surrounds the heart, all right? The myocardium is the myocardial muscle, is the muscle of the heart, is inflamed in some fashion, right? Here's an example of myocarditis. It looks like those who like red meat, that might look appetizing, all right? But it's very, very tough, I hear. And then, not human hearts, I don't know any cannibals. And then we got endocarditis, right? So endocarditis is, like we've touched on a lot with valve disease. That's really what it's going to lead to, right? Pericarditis and myocarditis kind of have a little bit of overlap. Like pericarditis can get so inflamed that it'll like kind of start touching the muscle of the heart, and it can even lead to perimyocarditis. But usually endocarditis is its own little thing, right? Usually that's its own thing. So we're going to talk about endocarditis first. That's a good segue from valves. And then we'll talk about pericarditis and myocarditis last. This example of all this junk that's built up inside the valves, right? That junk is made up of all kinds of bacteria and pus and clots and debris. So that's always going to make those valves not work good. They can either become stenotic or not close good, which is regurgitant, right? And that's affecting almost all the valves, really. But the valves that are held together by these chordae tendineae are which valves? Which valves are held together by chordae tendineae? Which is a fun word to say. It was a close second to my username for most things. The AV valve, specifically AV valves, right? So the mitral and tricuspid are held together by the chordae tendineae. And we didn't point out, but you can get valve symptoms, or when you have your papillary muscles that hold those together, that can cause those valves to become incompetent all of a sudden because you had a heart attack, right? The heart attack vessel feeding that papillary muscle fails, and then now you have an incompetent flapping valve in the breeze. All right, so infective endocarditis. So i.e., they have your endocardium is inflamed, and specifically it's being most inflamed around the valve itself, because that's the area of the most turbulence and the area for the most hiding out of bacteria. It has little spaces and crevices and such, so that's where our bacteria will grow, and then it will cause the valve to not function, and then lead to valve symptoms. But also it can start leading, it's an infection. It's an infective endocarditis. So these guys are going to have symptoms of infection, right? So what are some symptoms of infection? You're going to get fever, and then get all the viral symptoms, or all the immune system symptoms, which are you get fatigued, malaise, you get you have muscle pain, you have all those, just infection, right? And a fever will go up. And then also we have some lab values we can look at. The white blood cell count could go up. And there's two other ones we can look at, which we do usually when someone's not in the hospital. It's called an ESR and a CRP. ESR is the erythrocyte sedimentation rate, and CRP is a C-reactive protein. Those go up with an infection. All right, so the mortality for this is 20 to 40%. So in the room right now we have, 7 people? That means 3 of you will die if all of you got infective endocarditis right now. That's an incredible amount, right? When you talk about mortality, less than 1% is doable. That is something that, like when medications are concerned, and even with medications even lower. But that's an incredible amount of mortality, right? All that turbulent blood flow can cause damage to the endocardium, and then it can lead to infective endocarditis. What puts you at risk is IV drug abuse. You are bringing bacteria from the surface of your skin and putting them into your bloodstream. Those bacteria are going to make their way all the way through the bloodstream, and they're going to percolate at the areas that are easy to percolate at, and that would be the crevices of the valves, right? And usually it's going to be on the side that has less pressure. So usually IV drug abusers have like a tricuspid problem. They'll gather on the tricuspid side. All right, and then repeated dental procedures. Not just every dental procedure. It used to be every dental procedure that gave you antibiotics to prevent endocarditis, but now it's just those who are getting repeated dental procedures. Those that are high risk, like pregnancy, it's a high risk. They have to take antibiotics to prevent the bacteria from their teeth that would then travel and get into the bloodstream and then percolate at the valves, right? So we give prophylactic antibiotics for those that are high risk and those that have repeated dental procedures, and also those that have got it before. That's not a good thing. Also, those that have a valve replacement, those ones would also get prophylactic antibiotics. That's an important teaching point. Say, hey, you just had valve surgery. If you go to the dentist, you do what? Take antibiotics beforehand. Hey, you're pregnant and you're going to go for dental work. You should have antibiotics, right? So that's the idea with prophylactic antibiotics. So in the top right there, we got tooth stuff happening, right? Also can happen with people who don't brush their teeth, don't do flossing, poor gingival hygiene. The whole reason you go to the dentist is not so you have clean teeth. Well, technically, the whole reason is so that you don't get gingival disease, and the gingival disease will grow to the point that it will then go into the bloodstream, and then now you got infective endocarditis, right? That's the whole idea behind getting your teeth cleaned, okay? And of course, it's painful. People seek out help because it's painful ahead of time. Those that are higher risk, besides being pregnancy, if they're immunocompromised, now that bacteria can really take hold. So diabetics, patients with HIV and other immunocompromised states would be at risk, would be needing antibiotics before dental work. Okay, rheumatic heart disease, again, that is more of a third world problem. Usually, you'll see it in America when they've immigrated here and say, oh, grandma never got her heart fixed, right? But that's usually a result of rheumatic disease. Rheumatic fever is the like the initial presentation of endocarditis, but you're not going to usually see that in America at least. All right, if you'll get endocarditis just because you had endocarditis before, that puts you at high risk. And then, of course, we mentioned collapses. Collapses are a direct route into our bloodstream. From the plastic from outside the body can make its way into the hole you put in it, and it will then make its way into the bloodstream. Okay, what is the treatment for an infection? Antibiotics, right? It's not caused by viruses, it's not caused by protozoa or fungi. This is caused by bacterial. This is bacterial endocarditis or infective endocarditis. So you get antibiotics, and when you have an antibiotic, like if you put like Neosporin, which is no longer recommended, but if you put Neosporin on a cut, that's going to, there it is. There's my antibiotic, right? It's on my cut. But if you're going to put antibiotics, like I'm going to just apply it to the mitral valve. How are you going to do that, right? So you have to do 4 to 6 weeks of antibiotics, going just kind of flushing past, and hopefully it goes by like, and it's a little relay race, and kind of gotcha, right? So it's going to take a second to get those antibiotics to be effective, right? So it takes about 4 to 6 weeks for that to happen. So there's bacterial sources, right? All these things are leading to these bacteria that get in the bloodstream, and those bacteria that are in the bloodstream can then they form a abnormal mass that then our body will then start forming thrombi against it, and white blood cells will attack it. And now you've got a perfect maelstrom or storm for that to move, right, and break apart. So those things can break apart and cause complications of endocarditis. Not only does it cause the symptoms of valve disease, but it will then, those little pieces can break apart in the bloodstream and go everywhere. It can go into the fingers and cause symptoms, and go into the lungs and cause a pulmonary embolus, and go to the brain and cause a stroke. It can go, it's hard for it to go back around to the coronary vessels, but it can cause all kinds of problems. Right, so you can see here all these things: poor dental hygiene, we've got IV drug abuse, invasive procedures, and we start getting a thrombus and all this bacteria percolating there, and then they're going to start causing symptoms of disease, right? And those symptoms will then cause those symptoms can be problematic in themselves. They can start causing heart failure problems and other issues, but eventually that huge clot of pus will then break apart, and it will then go to the kidneys and cause problems, and go to other organs, cause them not to work. Of course, the valve can get worse and worse, but ultimately the problem here is what's called septic emboli. So you get this septic source, this cluster of bacteria, and it embolizes elsewhere throughout the body. And it's almost like a spore or Starship Troopers, and it's going to go down, and it's going to go to that target organ, and it's going to start forming an abscess there, right? So now the bacteria now have arrived from an asteroid across the galaxy. All right. Anyways, hopefully you understood that reference. Anyways, you have other problems as well. All right. So we're going to have, obviously, you get fever, you get a white count, and those things, but really the complications are our problem. So what are the symptoms of this? Well, you're going to have fever, malaise. In the elderly, you have a lot of confusion. That's usually with every infection, they can get confused. They'll get like weight loss, night sweats. These are all with like our immune system working overtime, All right, we're going to get our immune system, when it fires up, you get a fever, you get malaise, you get sweaty, your SNS fires off. These are all symptoms of an infection. So how do you know someone has infective endocarditis? You're going to hear a heart murmur. Okay, so the heart murmur will be there. IV drug abusers just point out again that it really affects the right side of the heart. You're going to get symptoms of CHF depending on which valve is affected. All right, so you're going to have arrhythmias. You know, the valve gets affected, then the chamber gets dilated, and now you get AFib, a flutter. All right, so that's going to be a result of infective endocarditis. And then we get septic emboli to the extremities. This usually is not going to have someone seek out help. They might go to urgent care and say, hey, I've got this weird thing on my hand. But what's really going to have someone seek out 911 are the next complications there. But what's highly tested are these different symptoms on the hands, right? Those are septic emboli, little fragments of clots, fragments of pus from the valve, and they're making their way through the body and depositing on the palms or depositing on the fingertips, right? So if you look, it's nice that it's in alphabetical order, JOS. So J are Janeway lesions, and Janeway lesions are right here, and they're painless. They're on the palms, so you can think palms for painless. All right, it's two P's, I guess. But then you have O and S, Osler's nodes and splinter hemorrhages, and those are at least the Osler's nodes are very, very painful. So you can see this little deposit there. It's inflammatory, and it's going to cause a lot of discomfort. And then under the nails right there, all of you got to check your nails right now. So I've got endocarditis? No, I'm good. All right, so it can then cause splinter hemorrhages underneath the nail beds. That's a sign of septic emboli before it leads to the big embolus that will then go from the heart out to the brain, out to the lungs, out to the kidneys, out to the spleen. It'll go everywhere, right? And that would be, that's here, septic emboli to the brain being the most common. I think it's like 65% of the time, right? And then what besides that, if it does get to the target site, it can then form abscesses at those sites. So it can deposit in the brain. It's like, oh, you got stroke symptoms, but now you got a big abscess in your brain growing because of the septic embolus. And it causes permanent CHF. If it's the valve disease, if it's not treated, can then cause permanent CHF. Diagnostic tests, how you know you have it? Well, blood cultures are going to be an important reason to identify what the organism is. It tells you if you're on the right antibiotics as well. How long are the antibiotic therapies? About 4 to 6 weeks. They're extended. Okay, so TTE is done first. Someone has any heart problems, they're going to look at their heart, and they're going to see it in 380p. Right? If you ever bought a TV from the early 2000s, that was 380p. I know I spent part of my FAFSA check on a TV. I was like, oh, that's perfect, right? I was a poor college student. That's what I felt was important to that time. Anyways, we have so TTE is identify the organism. Identify that there's vegetations. Vegetation is a fancy word for accumulation of pus, clots, and bacteria. All right, so do you see something weird on the valves? So right here, we see something weird. Look at that little guy like hanging out right there. And that guy can easily get dislodged and make its way to the brain, right? And then, or little pieces of it can get dislodged and go underneath the nail beds and cause splinter hemorrhages, right? Or go to the palms and cause what? Janeway lesions, okay? So there's also a 90s reference right there. All right, so you have a TTE. If you see vegetations, now guaranteed they have a TE in the future, right? So say, hey, what did you see on the 2D echo of the chest? All right, the transthoracic echo. We saw vegetations. Okay, so should we prepare for a TEE? And how do you prepare for TEE? Consent. Do you get consent? No. You print out the consent form. That's fine. Your whole purpose of the RN for a consent is to make sure the patient was not coerced. They were not under like heat lamps and water torture. You're making sure that they understood the risks and benefits and alternatives of the TEE. And so that you would make sure the doctor says, hey, aren't you going to tell them about hypotension? Well, that's not a risk. Well, shoot, I'm not going to witness this then, right? So that's the whole purpose of consent. Okay, that they understand the risks, and the risks being that they could aspirate, they could have hypotension from anesthesia as they do that procedure. But again, that procedure is 8K. It's like incredibly clear what is going on, if that is a vegetation or not, so they can figure it out at that point. Right, and then the blood cultures will let us know what organism it is and make sure that we're on the right antibiotics. Okay, it could go everywhere. We have splinter hemorrhages, we have the different nodes on the hands, all this junk building up there. Can make its way to the eyes even. It can go to the brain is most common though. So when we talk about strokes in 2 weeks, that's when we talk about with a septic source or a cardioembolic source. So pericarditis. So pericarditis is the outside layer. So we're shifting gears. So we talked about the inside layer, which is endocarditis. Now the outside layer, the outside of the heart itself, right? The pericardium is now inflamed for some reason. And why is it inflamed? 85% of the time, I have no idea, right? But usually, if we have to bet, it'd probably be infectious, so a post-viral syndrome. You got a viral infection, you got bacterial infection, you have an infection of some sort. It can lead to pericarditis. We mentioned with MIs, besides complication of CHF, they can get pericarditis, as usually happens about 3 months after their MI, about 20%. So 1 in 5 MIs will develop pericarditis eventually. And then there could be autoimmune reasons. So Med-Surg 2, we talk about a bunch of autoimmune conditions like lupus and rheumatoid arthritis. That can lead to pericarditis also. And then you can have other complications like trauma. You get stabbed in a sterile way or you get stabbed in a non-sterile way. These things can cause a pericarditis. And then what else? So drugs and toxins can do it as well, but then uremia, that's your BUN, right? It's people with a elevated BUN, like in what disease process? Who has elevated BUNs? Kidney disease. So in end-stage kidney disease, the BUN can climb and they can present with pericarditis as a symptom. All right, so the treatment for this is just give anti-inflammatory drugs, and the anti-inflammatory drugs we give are usually aspirin and NSAIDs. And then colchicine, it's usually used for gout, but it's also great here. It actually stops the white blood cells from going inside the pericardium and causing the pus and purulence from occurring. They might need steroids if this keeps happening. Pericarditis can be gone in a month, and it can recur every other month after that. So it can be a recurrent disease process. That can be difficult, and that recurrent pericarditis can lead to what's called scarring or restrictive pericarditis. We'll talk about that in the next slide. All right, so we have all these reasons for a pericarditis, and that pericarditis is going to be inflamed, and it's going to start be inflaming up against the lungs are actually going to kind of compress it, right? And that inflammation is going to compress it, and that's going to cause pain, right? So we call that pleuritic pain. So pleuritic chest pain. All those lungs are they're not the problem, but they are going to start touching up against that inflamed pericardium, and that's going to cause some chest pain, right? So that chest pain can then, as we'll show in the next slide, it can be positional. So if we were to lay backwards, all the lungs are now going to fall on top of the heart, right? And now the heart has to be up against those lungs that are putting pressure on it, so that's going to hurt a lot. So it's positional chest pain. When they lean forward, now the lungs are off the heart, and they're going to not have the pain as much, or might be even gone. Okay, so you have elevated inflammatory stuff, right? White blood cells, CRP, ESR. They get pleuritic chest pain, right? So we have troponins might be elevated, not really, but they'll have EKG changes, and it'll be like ST elevation. Like, oh shoot, they're having an MI right now. But as you learn in Med-Surg 3, when you look at an MI on the EKG, it's usually just in one area. It's not all of the leads, right? All 10 or 12 of our leads. So that's something to differentiate if it's a MI or just pericarditis. And also they have PR depression. Right? Usually we never talk about the PR interval is never up or down, but if it's depressed, that's pericarditis. It's like really a huge clue that it's pericarditis. We mentioned constrictive pericarditis or restrictive pericarditis as it gets scarred over time. That will cause difficulty for the heart to expand. That'll put a lot of extra pressure on the heart. But then what else puts pressure on the heart is an effusion. Anytime you have an infection, white blood cells go to that area and they're going to cause pus to develop and effluent to develop and more fluid to show up. And that fluid around the heart is not a good idea. Now the heart can't expand completely. It can't fill with blood completely. It's put a lot of extra pressure on the heart to the point it can't expand anymore. That's called tamponade, right? So cardiac tamponade is where the heart can no longer expand because there's too much fluid around it. So this guy has pain when? lying down. So pericarditis is positional chest pain. The chest pain is, when we talk about like heart attacks, chest pain is not positional, right? Chest pain is pressure on the chest and it radiates, right? Pericarditis is chest pain, but it gets better when I lean where? When I lean back or lean forward? Does it get better when I lean back or forward? Or does it get worse when I lean back or forward? Because the question can be either one, right? So let's answer the first one, which I don't know which one it was. But if I lean forward, does the pain get better or worse? It gets better. If I lean back, does the pain get better or worse? It gets worse, right? So it's pleuritic chest pain, those lungs on the chest, and when they breathe and they inhale, all that air goes into the lungs, they get bigger and put more pressure on that pericardium, right? You can also auscultate a pericardial friction rub. It's really, really hard to listen, especially in the hospital with the Zambonis going by and people going in and out, dietary knocking. It's really, really difficult to hear. But like an office setting where it's super quiet and you can record it, you might be able to appreciate it. It's a pericardial friction rub. It sounds like leather going back and forth over itself, a squeak of leather. And it's best heard on the left sternal border, okay? And also on the left side, you get the pericardium all the way up against the chest, the heart all the way close to the chest. You're going to hear it better then. Okay, this guy's chest pain feels worse or better when he's leaning forward? Feels better. All right, EKG, we mentioned you can have PR depression. The PR interval is actually depressed. So when you see that in clinics, like, oh shoot, they probably have pericarditis. All right, they're going to have infection symptoms, just like endocarditis. They're going to feel malaise, fever, they're going to diaphoretic, they're going to feel fatigued. That'll be, every infection has those symptoms. And the labs and diagnostics, they're going to have inflammatory stuff going up. We'll do blood cultures to make sure it's not something else that's causing this infection. They might have an MI with ST elevation, right? And then echocardiogram will let you see this huge pericardial effusion that's around the patient, right? So all that fluid is around the heart. There should only be about 20 to 40 mLs around the heart. And then if you have that much around it, that can cause that heart to not be able to expand and fill with blood for the cardiac cycle. Okay. You can also see it on chest x-ray. You can see that on the x-ray, the heart is huge. Right? So do you have a history of CHF? No, because CHF has elevated a big heart on x-ray. All right, but so then they might have pericarditis. All this fluid and effluent and pus is building up around the heart. So the complications of pericarditis, the complications being an effusion. So this fluid that builds up around the heart here, it will make the heart bigger in size. And like you or I right now, if we don't have pericarditis, right, or an effusion around the heart, we have about 20 to 40, 20 to 60 mLs. And if I were to inject your heart right now with a long needle and put 20 more cc's in there, you would die, 100%. Right? That's just 20 cc's of fluid. But these guys, when they have pericardial effusions, you pull out like a liter of fluid out of their heart. Over time, you can stretch and stretch and stretch that pericardium, and the heart can compensate and compensate. It has an ability to compensate over time. It's just like the guys that like think this is cool, right? If you put this huge big disc the first time, it's going to hurt, right? It's your ears going to feel like it's going to fall off. But if you were to work at it every month, every 3 weeks or so, every 2 weeks, and upgrade in size, upgrade the gauge size, you can compensate. Your body can do amazing things. Okay, so pericardial effusion can happen, and it can cause weakness and signs of heart failure as that right heart is trying to dump blood into the right ventricle. But it can't, because there's all this fluid that's compressing it, right? The right ventricle can't fill with blood effectively. So now all that blood backs up into the system. So we get what symptoms of right heart failure? You get swelling in the legs, you get peripheral edema, what else? So you're starting toes to head. Usually I do head to toe, that's cool. All right, so toes to head, let's go backwards. So the toes get edematous, get dependent edema. And then going back up, what's the next first organ system? The kidneys. The kidneys are going to start to decompensate, and then the next one is the gut, right? So the gut, they're not going to want. Are they going to want to eat or not want to eat? They're going to have anorexia, which means not wanting to eat, and then they can get nausea, vomiting too. But then it's going to back up into the spleen. You get splenomegaly. You get back up into the liver. You get hepatosplenomegaly. And then back up all the way up to the head, you get the neck swelling. You get JVD, jugular venous distension. Those are all symptoms of right heart failure, which can be a result of complications of pericarditis. All right, and then we talked about if over time you get recurrent, like you fixed it, and then they get the same symptoms again. Oh shoot, my pericarditis is acting up, right? They then have they can get scarring, and it's not like a hole full of fluid kind of situation. Is the pericardium can't stretch at all because it's been scarred over. They do a pericardiectomy. They actually remove the pericardium. So that's a fix for that. All right, so then, and that also has symptoms of right heart failure because you can't dump blood into the right ventricle because the pericardium is so restrictive, it won't let it expand. All right, and then cardiac tamponade. So you'll talk about tamponade in Med-Surg 3, we'll talk about it in Med-Surg 2, and we'll talk about it here as well. That's where all this fluid is to the point where it is tamponading. It is preventing the expansion of the heart altogether, and if you can't fill the blood with heart, what's going to happen to your blood pressure? Go down because you can't fill the blood with the heart with blood, and therefore you don't get blood coming out of the heart, right? Also, you're unable to eject blood from the heart because there's so much pressure. The left ventricle wants to fill with blood, but it can't. It's obstructed, right? So we call that what's called an obstructive shock. So the shock just means a low blood pressure. So we're unable to pump blood out of the heart because it can't fill, and it can't really contract and put the blood out, right? The pressure's so high, right? And because you can't fill with blood, you're going to get JVD. The blood's going to back up into the neck there, right? You get JVD and low blood pressure. And what the heart sounds? You're going to hear the heart well. It's going to be all distant behind the effusion. That was one of our symptoms of pericardial effusion. It's just a pericardial effusion that's got to the point where it's prevented the heart from even filling at all or being able to contract at all. So you have distant heart sounds, JVD, and low blood pressure. That's what we call Beck's triad. He discovered it first, so he gets to put his name on it. So Beck's triad is when you have all three of those things, it's like, well, shoot, they probably have cardiac tamponade, right? Until proven otherwise. That's a medical emergency. That's if someone has really bad JVD, they can just have right heart failure. But all of a sudden the blood pressure is low. That's very, very worrisome, right? Distant heart sounds, get out of here. You didn't hear distant heart sounds, right? That's really hard to hear. Oh yeah, they were distant. What do you mean they were distant? How do you know if they were proximal? Right, that's really hard to assess. But definitely you have JVD and you have low blood pressure. That's gonna be a situation. They're probably not gonna look great. They're gonna have their SNS kicking off. They're gonna have a feeling of impending doom. They're gonna say, I feel like I'm dying. They're gonna have really a lot of anxiety. They're gonna be breathing really fast. They're gonna be really, really diaphoretic. That's a really bad situation. They have these features as well. You can see this heart is like just dancing in there, right? It's going back and forth with all that fluid. It's sloshing, right? With each beat, when it beats, it's like moving itself through all that fluid. And it beats the other way and it moves the other way through the fluid. And you can actually see that on the EKG, right? The EKG is on the chest, right? Your chest isn't moving that much, but your heart is going back and forth, back and forth. You can see the change in the complexes with each beat. As going back and forth. It's called electrical alternans. It's getting high and small. It's getting tall and small, the EKG complex. Also, when they take a big, big deep breath in, there's more volume of air in the chest, and that's going to prevent the heart from filling with blood because now the air is in the chest. So when the thoracic pressure is increased, that can make our blood pressure change as well. You can see that in the pulse ox waveform. You can see the pulse ox waveform is getting big and small, big and small. It's like, well, why is your pulse ox is good? It's really tall here and it's small then. It's going with your breathing. Well, sir, you have cardiac tamponade. All right, so how do you fix that? You just take the fluid out. That makes sense, right? If the fluid is causing the problem, you take it out. So if it was a stabbing situation, it looked bloody, right? But if it's pericarditis, it's going to be cloudy with all that extra white blood cell and infectious processes that are in there, right? So you pull all that fluid out. So they can do that at the bedside with a huge needle, right? And they can pull all that fluid out. And if it's a lot of fluid, they might hook it up to a drain, and then it'll drain like 500 cc's even. A lot of blood, a lot of fluid at least. Okay. If it's recurrent, it's happening over and over and over again, we can put a window into their heart. All right, so I'm gonna. What kind of surgery are you consenting for? I'm consenting for a window into my heart so you can see me better, babe. No, all it is. They put a little square. They just poke a little hole in it, right? And now the fluid can leak out, and it can go into the lungs or around the lungs, not in the lungs. Go around the lungs and then get reabsorbed naturally by the body. So it's a way to kind of fix the situation if it's happening over and over and over again. Okay, so it's called a pericardiostomy, where we're putting a hole inside the heart. So carditamponade is the heart is unable to contract, unable to fill with blood, and everything can't fill, so it backs up into the venous system, we get JVD, right? And we're gonna get a low blood pressure because we didn't fill the heart with blood. So that's gonna cause low blood pressure. And we fix it with a what kind of procedure? Pericardiocentesis. All right, so myocarditis, or last itis of the heart, last carditis. So it's inflammation of the myocardium, so it's myocarditis. All right, so it can be separated into infectious reasons or non-infectious. So infectious being the most common. We had a virus recently. So they had a flu recently, they had parvovirus, they had herpes virus, they had all these different viruses. Any kind of virus can lead to this problem of the heart being the consequence of this inflammatory process. When we form that attack against the virus and our immune system fights it, it also attacks our heart muscle, unfortunately. So that can happen with and cause myocarditis. And then there's non-infectious sources. There's meds out there, heavy metals. There can be certain bacterial sources that might cause again, our immune system to attack our heart and cause us to have a inflammation of our myocardium. And then there's the Chagas disease, which I've found now that it's kind of found in the states as well, the lower southern states. So I thought it was only a fear that would be only if I moved to South America, but and it's also in the states where the bug goes at night and it bites you on the face. It's called the kissing bug. Gives you a little kiss at night, and then you scratch it, and then it gets in your nails, and then it gets into your system. You can self-inoculate yourself, and then it goes and it deposits itself in your heart muscle, and then you have heart failure, right? You get myocarditis first, and the myocarditis consequence is that you get heart failure. I figured, okay, cool. The bug kisses me at night. It's like a tick, right? Like really, really small. No, it's that big. It's crawling your face, and it's huge. So that's another fear unlocked if I move to the south. All right, and Lyme disease happens in only specific states as well with tall grass. Those things, these sources of bacteria or sources of virus or medications, all these things are going to cause our heart muscle to be the end consequence. Right, and our heart muscle gets inflamed, and then we get AV blocks can develop. We can get ventricular tachycardias that can develop, and then ultimately you get a cardiomyopathy, which can develop. You get CHF out of this whole thing. There usually isn't a fix for it, unless, yes, you can replace the heart, but there's no like official fix for this. You just kind of muscle through it, no pun intended. All right, and then myocarditis, like in athletes, it's like number one, or is it number three? Number three, third reason cause a sudden death in an athlete. So athletes just on the field, in the soccer field, and they keel over and they die. So it could be because of myocarditis, that a recent viral infection. So there's a huge algorithm out there in sports medicine. It says if someone has an infection, they cannot go out and play until that infection is completely gone for X amount of time, because they can develop myocarditis. You look at here the years of myocarditis and people suddenly dying of myocarditis on the field. Number of sudden cardiac deaths, we passed 300 and with COVID. So COVID happened in 2021, 325 athletes just died suddenly, right? Just going to sports practice, died, right? So it's a serious situation. Right, hypertrophic cardiomyopathy is like number one reason for athletes. That's usually genetic. They don't usually know that until they die. And then arrhythmias they could have some kind of congenital situation with arrhythmias. Right, you'll talk about all the congenital heart diseases in pediatrics, and that's fun. That's where murmurs come back, and you have to know all about flow of blood through the heart and pressure systems and all kinds of fun stuff. All right, so our last slide is the symptoms of myocarditis. It's going to have chest pain. You're going to have persistent chest pain. It could show some ST changes, but usually the EKG doesn't show the ST elevation or ST depression. If it does, they might go to cath lab, and the cath lab said, hey, their coronaries are perfectly clean. They're open. It's not a myocardial infarction. It might be myocarditis. And patients that come with an MI, they are not infectious, right? So, asking the patient what their history is, if they have a fever recently, have you feeling weak over the last 2 weeks? Yeah, I went to a party 2 weeks ago, went to grandma's party, they all had COVID. So, well, shoot. Or they went to grandpa's party last week and they all had flu. They're all coughing, right? So that might be the reason why you have this chest pain right now, and why your watch always says, hey, your baseline heart rate's 140. right? Some people taking the test last week, that was their baseline heart rate. But with me, it's like, I got myocarditis, right? But that's a persistent tachycardia all the time. Like your heart's like working overtime. Signs of fever, signs of inflammation, those are all suggestive of myocarditis, especially if the chest pain is there, right? And then got into the CHF. That's pretty bad if you get CHF for your myocarditis, and that's really where they should seek out help, and that can be an ultimate downward spiral for their myocarditis. If the CHF gets worse and worse and worse, it can lead to a shock state where the heart can't function anymore. So labs and diagnostic tests, we can do an EKG to see if there's a heart attack happening with their chest pain. But they might have an AV block, as we mentioned. They might have VTAC, VFib. They can have what's called a low voltage EKG, where the complexes are small all the way. I don't know if you've seen that in the clinical, and you have to zoom in 3 times to even see their complexes. It's possible it could be this situation, or they just have extra tissue to hug. And then we got the echo. They might have the echo would tell us that it shows the walls are inflamed a little bit, but it might show those walls that are inflamed aren't working as good as they could. If they go to the cath lab, the coronary vessels are clean, and you realize it might be the myocardium that's not working. And then it's rarely done, but it's official. It'll tell you that you have myocarditis. They'll do a biopsy of the heart. They're going to stick a needle into your heart and take a little sample, right? And they say it will tell you exactly what is growing there. It'll say, hey, you got COVID, or you got you have Chagas disease. You have just a deposition of immunocomplexes like an amyloidosis or something weird, right? So those are consequences of those disease processes, and you can officially say they have it when you do a biopsy, right? So things to look out for: do they have dysrhythmias? Do they have CHF? And initially they should take antivirals. We have like Paxlovid for COVID. We have We have Tamiflu, what's the brand name? Oseltamivir for influenza. We have different things out that we can do to treat it. Okay, so that's the idea. And then they might have to be on immunosuppressants, like if they have some autoimmune condition, they might have to be on those for a long time. All right, so that's the idea behind myocarditis. Our myocardium getting infested with either like Chagas disease or Lyme disease, or we are forming an attack against the virus. And when we have those things, the same antibodies that attack the virus will also attack our myocardium, and our myocardium gets destroyed, and we can lead to permanent CHF. All right, so that's it for valves and carditis.